Welcome to the Resident's Guide on Atrial Fibrillation. Let's get right into it. So in my opinion, this is the perfect medical student teaching topic, but then make sure you stick around because then I'm going to talk about how not only is this the most perfect medical student teaching topic, but it's also the perfect teaching topic for interns. And there's a lot of key learning points that interns can learn as well. So in terms of teaching medical students, I kind of go through a set list of things that I try and go through. The first thing I start off is just basically asking them, what is the definition of AFib? And usually what I do is I draw out a heart, and I talk about how AFib is the abnormal generation of electrical activity that ends up causing the atria to basically just be quivering all the time. And so you get a really irregular heartbeat. Medical students should also be able to identify the EKG rhythm. And I usually show them a picture or draw it out for them, showing them the fibrillating baseline with no clear P waves and then the irregular rhythm, which is something that they should know to say when they're doing their physical exam presentation. In terms of common causes, I ask them if there's a common mnemonic that they like to use. And my favorite one is PIRATES. So P stands for pulmonary, post-op, or PE. I stands for ischemia. R stands for rheumatic heart disease. A stands for anemia and alcohol. T stands for thyroid and toxins. E for electrolytes and endocarditis, and S for sepsis and surgery. And so this is a really nice mnemonic that your medical students can use to know some common causes of atrial fibrillation. In terms of complications, I make sure that students know why we care so much about atrial fibrillation. And basically, number one is stroke and TIA. So I make sure that they're fully aware of that. And number two is going to be AFib with RVR, which can lead to hemodynamic compromise and decreased cardiac output. So one thing I like to do is really just help them visualize why strokes and embolic events are a risk. So I tell them, imagine that this atrium is just quivering the whole time. The blood is very stagnant, right? So it's kind of just stagnating and just not moving very well. And so it's very easy for you to form a clot. And one question to ask them is, where is it most common that you're going to get a clot? And the answer to that is going to be the left atrial appendage. And this is another high yield piece of information for a medical student to know about. And then the risk of stroke is because at any moment, this clot, while it's here, could theoretically shoot up and go embolize to your brain and cause a stroke. They should definitely be aware of the risk scores that we use for AFib, including the CHADS-VAS score and the HAS-BLED score for determining whether we want to start somebody on anticoagulation or not. And so I totally go through this with them and make sure they know it very well, because this is going to be something that's very pimpable and something that I was pimped on as a medical student as well. And then briefly, we'll talk about management with medical students, including rate control, rhythm control, anticoagulation, and cardioversion. And once I kind of get to this point, this is when I kind of transition into talking about a level for an intern. And so this is why atrial fibrillation is such a perfect teaching topic, because not only is it going to be beneficial for the medical students on your team, but also the interns are going to be able to learn a lot as well. So in terms of the knowledge that interns should start to know about, there's a couple things that I do like to go over. The first one is the origin of AFib. And what I mean by that is I want them to know where AFib actually originates in terms of the right atrium or left atrium. And a lot of people think that it starts in the right atrium, but atrial fibrillation is actually a left atrial sided process, okay? And the source of atrial fibrillation actually comes from abnormal electrical signaling that's around the pulmonary veins, okay? So important to know that the source is pulmonary veins. So basically what happens is you start getting all these abnormal electrical signals coming out from the pulmonary veins. And this totally explains why a lot of times you get atrial fibrillation when you have a dilated right atrium, because it's going to stretch out these pulmonary veins. And there's a lot of electrically active cardiac myocytes in that area. And they start sending off all these fibrillating different waves, which are really the cause for atrial fibrillation. And this is very relevant to know because in contrast, the source of atrial flutter is usually the right atrium. Okay, so atrial flutter in the right atrium and atrial fibrillation in the left atrium. And the area that's affected in A flutter is called the cavo-tricuspid isthmus, or the CTI. And basically you get this reentrant loop in the cavo-tricuspid isthmus. And so this really impacts the treatment, because one of the treatments for both of these conditions is ablation. And with ablation, basically what they're going to do is they're going to burn off these circuits to prevent all these abnormal electrical signals from going off. So for atrial fibrillation, you're basically going to go to the left atrium and ablate all this tissue around the pulmonary veins, and that's going to stop your abnormal signals. Whereas in atrial flutter, then you go for a CTI ablation, where you basically cut this reentrant loop at the cavo-tricuspid isthmus. Another potential surgical procedure that you should be aware about is called the maze procedure. And this is basically when they go in surgically and they just like make cuts everywhere, and basically all in the left atrium, it's just cuts. They make it basically into a full maze. So no electrical signals can really go anywhere. And that basically stops atrial fibrillation. One thing you should also know about in terms of ablation risks is that, it's not a procedure that's without risk. And one of the risks is actually bleeding. And one of the things that can actually happen is that the left atrium is right in front of your esophagus, and they have to put a probe. They usually do a TEE while you're getting your ablation. And so they measure the temperature of that area that they're burning, because one of the risks is that they burn too much and it actually burns through and goes into your esophagus, and you get very significant bleeding if that happens. In terms of duration and terminology, interns should all know about the difference between paroxysmal, persistent, long-standing persistent, and permanent AFib. So paroxysmal stands for atrial fibrillation that is intermittent and lasts less than 7 days. Persistent is any atrial fibrillation that lasts for longer than 7 days. Long-standing persistent is atrial fibrillation that's greater than 1 year in duration. And then permanent atrial fibrillation is basically after you've given up. So they've tried multiple therapies, multiple agents. Sometimes they've even tried ablation. And basically at this point, you've given up and you're just going to let them be in AFib. You're just going to try and control their symptoms. Very important to know the different definitions, because when you're writing your notes and documentation, it's important to put what type of AFib the patient has. Next, you really need to know the difference between valvular and non-valvular AFib. The reason it's important to know this is because the treatment for valvular AFib is going to be warfarin, because DOACs have not been studied really well in this population yet. And then in non-valvular AFib, you can do DOACs, which are a lot easier for patients to take. So what is the definition of valvular AFib? Well, the definition used to be a little bit more broad and used to include all types of valve replacements, but now it only includes mechanical valve replacements and rheumatic mitral stenosis. So again, very important to know the difference between valvular and non-valvular AFib, because valvular requires warfarin rather than DOACs. And then secondly, it's very important to know that valvular AFib is only defined by two things: mechanical valve replacement or rheumatic mitral stenosis. Next, when I'm talking with interns, I like to go over some common trials and very important trials that they really should know about. So in terms of rate versus rhythm control, there's a very famous trial that you should know, and that's called the AFFIRM trial, and I believe it was done in 2000. And this basically showed us that rate control is non-inferior to rhythm control. So rate equals rhythm control. But the benefit is that rate control tended to have less side effects, whereas rhythm control had a trend towards higher mortality and also had higher side effects. So this is definitely the reasoning why a majority of the time we actually end up starting with rate control rather than rhythm control. In terms of the goal heart rate, I like to ask the interns, what is our goal heart rate in terms of controlling somebody's AFib? And the answer to that is goal heart rate less than 110. And the trial that we have that showed this was called the RACE-2 trial, and this is a very important trial to know. But basically, they had a strict heart rate control group of target heart rate less than 80 and a lenient heart rate group of target less than 110, and they compared the mortality between the two, and they actually found that the group with the more lenient heart rate goal of less than 110 had superior outcomes. Okay, so our goal heart rate in atrial fibrillation is less than 110. If they are symptomatic, however, then you should aim for less than 80 or less than 85 if they are feeling their palpitations. But if they're not symptomatic and they're not having any problems with their AFib, goal heart rate is less than 110. And finally, an important new trial to know is called the EAST AFNet 4 trial. So this trial is actually showing that rhythm control may be better than rate control. And this is something that just came out, I believe, in 2020. And so this may be practice changing and may lead us more towards using rhythm control agents in the future. The current thought for why this trial showed a different result compared to the AFFIRM trial is because there were different agents being used in the EAST AFNet trial. For example, more flecainide and propafenone and dronedarone, compared to the AFFIRM trial, which really was using a lot more amiodarone and sotalol. So again, 3 important trials to know: the AFFIRM trial, the RACE-2 trial, and the EAST AFNet 4 trial. Next, I like to go over agent selection because a lot of times interns want to know, how do I choose the best agent, especially if somebody's having acute AFib with RVR, which agent do I choose to try and control their heart rate? If you're enjoying this content and finding it useful, please consider subscribing and letting me know down in the comments that you subscribed, and I'll be sure to respond to you and make more content like this in the future. And so I'm going to need a little bit more space for this, but I made a little table with the different agents you can use. So we've got metoprolol, diltiazem, digoxin, and esmolol. And again, this is going to be for acute rate control in patients with RVR. So for metoprolol, the dosage is 2.5 to 5 milligrams IV every 5 minutes for 3 doses. Obviously, if they have a good response to the first dose, then you just need to do that first dose. And generally, we will just do 5 milligrams. But if you're a little bit worried, then you can start with the lower dose of 2.5 milligrams. The patient population which metoprolol is particularly good in is hyperthyroidism, because you're obviously blocking that peripheral conversion of T4 to T3. The patient population that you may want to consider avoiding metoprolol in is patients with reactive airway disease, because obviously you're giving them a beta blocker, whereas the treatment for reactive airway disease is actually a beta agonist. In general, I would say that metoprolol is kind of my go-to as the first agent I'd like to try, because it's just a very simple one to give and there's not too many side effects of giving it. The next agent that you can consider is using diltiazem, which is a calcium channel blocker. The dosage for this is usually 0.25 milligrams per kilogram as an IV bolus, which is usually around 20 milligrams. Then doing a 0.35 milligram per kilogram bolus if they don't respond very well to the first one. And if they're still not responding to that, that's when you start them on a diltiazem drip with a rate of 5 to 15 milligrams per hour. The good thing about diltiazem is that it has a stronger AV blockade than metoprolol. So if they're not breaking with metoprolol, there's actually a higher chance that diltiazem is going to break them out of that AFib with RVR compared to metoprolol. But the big thing that you need to know with diltiazem is that it has a black box warning for increased mortality in systolic heart failure. And the reason for this is because the negative inotropic effects of diltiazem is higher than with metoprolol, and so you actually have a risk of precipitating cardiogenic shock or worsening their heart failure when you give this medication. So that's the big reason you should be a little bit more careful with it. So diltiazem is kind of my number 2 pick, at least for me. This is really institution dependent, but it has a little bit more of a drop in blood pressure sometimes. It's stronger than metoprolol, and then also it can worsen heart failure if your patient has heart failure. So those are some reasons that you might avoid it. But you'll see this very commonly used in the ED because they like to just hit them hard, and it's very effective. The next agent, which is kind of more of like a second line agent, is going to be digoxin. What you do when somebody's in RVR is you give them a 0.5 milligram bolus, and then you do 0.25 milligrams every 6 hours times 2 to get them like a 1 milligram load over the first 24 hours. Then you get them on a 125 microgram to 250 microgram dose daily. This is really good if your patient is kind of borderline hypotensive or if they have heart failure, because that actually has a little bit of positive inotropy. The bad things about this is it's slow onset, so it takes like greater than 2 hours for it to really kick in. You do get digoxin toxicity, and you're going to have to measure their digoxin levels regularly. And usually this is really only added if you have poor control with a beta blocker or calcium channel blocker, and you need an additional agent to control the rate, then you might reach for digoxin. But this is definitely a good option if your patient is hypotensive and you're hoping that the digoxin will help a little bit with their blood pressure. Finally, the last option for rate control is going to be an esmolol drip. You start off with this bolus and then you transition to a drip. The good thing about esmolol, it has a very short half-life, so it's really easy to titrate, and you can turn it off immediately if the person is not able to tolerate it. So this is really good because if you're not sure they're going to tolerate a beta blocker, you can turn this on. If they're not tolerating it, you turn it off right away, and it's basically out of their system. The bad thing about esmolol is it provides a lot of volume to patients. So if you have any worry for volume overload, then giving them more volume through the esmolol drip may not be the best idea. Next, we're going to talk about rhythm control agents, and our big gun here is going to be amiodarone, and this is also good if the patient is hypotensive because it doesn't really affect their blood pressure like metoprolol potentially could, or diltiazem. The reason we use this in the acute setting is because it actually has rate control properties. Even if it does not provide any rhythm control right up front, it can help with rate control. There is theoretically, however, a higher risk of chemical cardioversion, so you have to be cautious if the patient has not been anticoagulated yet, because there's going to be a higher risk for a clot to embolize. One thing that I did want to bring up is that none of the previous agents that I've talked about, these 5 agents, should be given if the patient has pre-excited atrial fibrillation. In that situation, you give procainamide, or you just go directly to electrical cardioversion instead. And so what is pre-excited AFib? So pre-excited atrial fibrillation is going to be when you get an EKG that looks like this. You've got atrial fibrillation with an irregular rhythm, but you also have a wide QRS complex. And this is going to be very suspicious for a patient with an accessory pathway. And if you do any AV nodal blockade, which all those previous agents really kind of do, you have the potential for them to only be using the accessory pathway after that and causing them to go into like VFib, VTAC instead of just being an AFib with RVR. And then finally, if the patient is ever hemodynamically unstable, you go straight to electrical cardioversion. So let me just summarize this because that was kind of a lot of information. So first, metoprolol is kind of my go-to at least. Consider avoiding it in patients with respiratory disease, but it's a very well-tolerated initial approach to AFib with RVR. Diltiazem is going to be a little bit of a stronger hitter, but you got to make sure to avoid it in heart failure. Verapamil is also an option, but it's less common because it has more negative inotropy than diltiazem and more effects on blood pressure. So in my opinion, I don't really see this very often, and I would not really favor using verapamil very much. It also has toxicity with digoxin, so that's another reason not to use verapamil. If you're still having trouble with the heart rate, or if they've got heart failure or borderline hypotension, then digoxin is going to be a good option to reach for in the short term. And then esmolol drip, if you're unsure that the patient's going to tolerate beta blockers and you really just want to kind of have something that's fast on and fast off. Amiodarone is going to be another option if the patient is hypotensive, and I frequently see this in the ICU setting because a lot of those patients are hypotensive. They go into AFib with RVR, you're kind of limited in your options, and so you may just give them a bolus of IV amiodarone. Finally, if they have pre-excited atrial fibrillation, do none of the above. Go for procainamide or electrical cardioversion. If they're unstable at any point, electrical cardioversion. And then finally, don't forget to check electrolytes, because if somebody's potassium and their magnesium is very low and you give them a rate control agent, if you don't correct that electrolyte abnormality, then it's more likely that they're going to not respond to the medication that you give them. Now, a couple of extra questions. What is the definition of an appropriate response to rate control? The answer to that is going to be a greater than 20% reduction in the heart rate, conversion to normal sinus rhythm, or a heart rate less than 100 beats per minute. And what is it called if someone with AFib and RVR begins to develop heart failure symptoms? This is a question that I got as a medical student. And so it's important to know somebody has AFib for a prolonged period of time. Now they have heart failure. This is called tachycardia-mediated cardiomyopathy. So this is something important to know. What you should know is this takes several weeks for this to actually occur. So if somebody's in AFib with RVR and their heart rate's like 110, 120, and you can't get their rate down for a few days, it's not going to be a huge problem. They're not going to develop heart failure symptoms from that. But if you leave them in AFib with RVR for a longer period of time, then they may develop heart failure. Finally, is atrial fibrillation or atrial flutter more difficult to rate control? It's important to know that atrial flutter is actually a lot more difficult to control than atrial fibrillation. And so in these patients, you will try and do the same things, metoprolol, diltiazem, etc. But then you should also consider earlier ablation or electrical cardioversion in these patients. Next, let's talk about chronic rate and rhythm control of atrial fibrillation and atrial flutter. So rate control, we kind of already discussed, the basic medications that you're going to be giving. So beta blockers, especially if they have coronary artery disease or heart failure with reduced EF. Calcium channel blocker would be slightly preferred if the patient has chronic lung disease and you want to avoid beta blockers. And then digoxin to be added if the above two are insufficient. So rate control, pretty simple. But now let's talk about rhythm control. There's many different agents that you can be using. Amiodarone, dronedarone, flecainide, propafenone, dofetilide, sotalol. These are a lot of options, at least that I've seen in my experience so far. Before I go on, you should know that all anti-arrhythmics are actually pro-arrhythmic as well. And this is something that one of my attendings taught me. And so you have to be worried that when you're starting these agents on somebody, you can also precipitate some other kind of arrhythmia. Okay, so let's start with just a description of all of these different agents you can use. Starting with the most common one, it's going to be amiodarone. So amiodarone is really the big gun. It's the most effective. It's got the most side effects, however. Also has CYP450 inhibition, so it can really affect the medication concentrations of other medications that your patients are on. So this one is really, really avoided in young patients because the side effect profile is cumulative. If you start this medication in somebody who's 75 or 80 years old, the chance of them developing side effects over time is going to be a lot lower than if you're starting this in a younger 60-year-old patient, because they're not going to be on this medication as long. So the younger they are, the more hesitant you want to be with starting chronic amiodarone. In terms of the loading dose, you should know that it requires like a 10 to 14 grams to get fully in your body and saturated. Basically, the way one of my attendings put it is that amiodarone needs to get into like every single cell in your body to start working. And so that's why it requires so much of a loading dose before it starts. So a lot of times in the hospital, we'll give them an IV bolus, and then we'll do a 24-hour drip up to 10 grams. Then you do 400 milligrams twice a day for like 1 week. And then finally a maintenance dose of 100 to 200 milligrams daily. This may be a pimp question that you're asked, but the half-life is 1 month. So even after you stop amiodarone, for example, if somebody's having some kind of toxicity or they're getting a prolonged QTC, it's going to take months for it to come out of their system. So they're still going to have that prolonged QTC for a long time. So that's just something to know about. And then when you're starting this medication on somebody, you need to get baseline pulmonary function tests. You want to get thyroid function tests, liver function tests, and electrolytes every 3 to 6 months to check for any toxicity, and also get an annual chest x-ray. Make sure you're not missing any pulmonary fibrosis that's related to the amiodarone. All right, next let's talk about dronedarone. Dronedarone is basically a gentler version of amiodarone. It's weaker than amiodarone, but it's also got less side effects, which is the advantage. One thing that has been noted in several case reports, though, is that there is a risk of fulminant hepatitis, albeit it's very rare risk, so I wouldn't worry too much about that. Just know that that's one of the potential risks. Moving on, we have flecainide and propafenone, and these are both class 1C anti-arrhythmics, and very, very nice medications to use, but you have to know that you cannot use this in patients with structural heart disease. So if they've had like an MI before and they've got a big scar, or they've got some kind of valvular problem, stuff like that, and like severely dilated atria, they've been shown to have more mortality in people with structural heart disease. So very good class of medication, but do not use if there's any structural heart disease. One thing that's really good about these is that you can use them in a pill in the pocket strategy, where basically you have a patient on rate control, and then you give them this pill that they keep in their pocket. And if they start to feel palpitations, they'll just take a flecainide, or they'll take a propafenone and see if that controls their symptoms. If it doesn't control their symptoms, then they'll go to the ED to get further management. But this is a good way to help people kind of stay outpatient and not have to come to the ED all the time. If you're starting this, really you should get the cardiologist on board, because this is not something that a general internist is going to be prescribing all the time. Now let's talk about dofetilide and sotalol. So these are class 3 antiarrhythmics. Major side effect with these is going to be a prolonged QTC. And so I actually initiated one patient on dofetilide while they were in the hospital. And there is this whole complicated initiation protocol where you have to get multiple repeat EKGs and change the dosing of the dofetilide based on their QT interval. And also you got to like calculate a bunch of different things to make sure their QT interval is within appropriate limits. So biggest thing is the prolonged QTC. Usually you're going to see this in patients who have already failed multiple other therapies and there's no plan for ablation. Then you're going to be reaching for things like dofetilide and sotalol at that point. All right, so this is my basic approach to antiarrhythmics and kind of the key things you should know about each of the different antiarrhythmics that are available. And again, remember that all antiarrhythmics are also pro-arrhythmic. Let's go back to our overview of what I like to teach interns. So we talked about rate control agents in the acute setting. We talked about rhythm control agents in the chronic setting. Now let's talk about new-onset AFib. So again, I'm going to need a little more space. New-onset AFib. So atrial fibrillation, the first thing that you want to assess is this stable or is this unstable? If this is unstable and the patient is hemodynamically compromised, then basically you just go straight to cardioversion. If the patient is stable, then you basically start them on rate control, and then you assess, is this something that's onset within the last 48 hours, or did it start greater than 48 hours ago? And a lot of times if somebody's coming in outpatient or they're coming into the ED, you're not going to know exactly when it started. But sometimes people will have a Holter monitor and they know exactly when it started, or they were in the hospital on telemetry and they know exactly when it was started. So if it's less than 48 hours, what you can actually do is you can go straight to cardioversion with less than 48 hours. Whereas if it's greater than 48 hours, you're going to have to do a transesophageal transesophageal echocardiogram, and then you can do cardioversion. So the reason for this is because in the time frame of 48 hours, it's very unlikely the clot would have formed. So you can just cardiovert them right away with a very low risk of stroke or embolism. But if it's greater than 48 hours, there's a very high likelihood that a clot is formed. And so you need to do a TEE, and then you go down their esophagus, take a look with an echo and make sure there's no clot there. And once you can confirm there's no clot, then you can do a cardioversion. The other thing you can do for these patients is that you don't necessarily have to go for cardioversion right away. So with this trial in 2019, the RACE-7 Aquas trial, 69% of patients will spontaneously convert within 48 hours. And they also found that delayed cardioversion is not inferior to immediate cardioversion in achieving normal sinus rhythm at 4 weeks. So for both patients who come in with new onset AFib less than 48 hours and with AFib greater than 48 hours, you can actually also do a delayed cardioversion approach where basically you put them on 3 weeks of anticoagulation that basically rules out that they have any clots or basically prevents any clots from forming. Then you do cardioversion, and then you do 4 weeks of anticoagulation after that because they have some stunned myocardium from the cardioversion. They can still have a little bit of risk of forming a clot. And then this is a very viable strategy as well. So definitely know the different treatment options for immediate cardioversion in patients with less than 48 hours and greater than 48 hours, but also know that delayed cardioversion is an option as well. And it's going to be sometimes attending preference. All right, so that was my quick residence guide to atrial fibrillation, both A, in terms of how you can teach your medical students, and B, important topics that interns should be able to know as well. I highly recommend you practice using atrial fibrillation as one of your first topics for teaching medical students. As you can tell, it's one of the easiest ones and one of the most high yield and relevant topics that you can do because it's the most common arrhythmia and so many patients are going to be coming in with AFib. And so here's just an example of some whiteboard teaching that I had been doing in the hospital and kind of going over a lot of the things that we talked about today in this video. If you liked this video, then please consider subscribing and letting me know in the comments down below that you liked this content, and I'll be sure to make more videos like it in the future. Thanks for watching, and I'll see you in the next one.